Thank you for the opportunity to speak today. So I'll be speaking on a topic that we don't often see, but especially with Dr. Hadjipannyis here, we tend to do a lot of these cases, which are the surgical treatment of colloid cysts. I have no disclosures. As far as just a brief outline for what we'll be speaking about today, first I'll give a very brief case presentation on a case we did recently of a patient with colloid cysts. We'll talk about the history of the pathophysiology, the epidemiology, diagnosing colloid cysts, the pertinent imaging, surgical management, specifically focusing on the endoscopic treatment of colloid cysts, and then some of the outcomes data that we have. So just to present a quick case. So this is a 53-year-old female with a history of hypertension, migraines, a prior stroke a couple years ago, on aspirin 81 daily, who had taken aspirin upon admission. And a known colloid cyst that was being followed with serial MRIs presented to the emergency department with persistent severe headaches. On exam, she's ANO ×3, all cranial nerves are intact, really a non-focal exam with the exception of gait instability. So if we have any of our medical students available, I wanted to start by just asking what some of the imaging you would do initially on this patient would be. We already have prior MRIs, but now that we're consulted on her in the emergency department, what would be our next step? Let's see. Do we have Michael? Is Michael available as a panelist? Maybe not. Is Will, our other sub-I, available?
Yep, just give me a minute.
Yeah, sure.
Hey, we just got added as panelists.
Hey, hey, Will. So we have this 53-year-old female, known history colloid cyst, who comes into the emergency department with persistent severe headaches. On exam, she's pretty non-focal. The only pertinent finding is that she has gait instability when you walk her, but other than that, a non-focal exam. So what would be some of the imaging that you would want the emergency department to get?
Given her history with a prior CVA and her acute presentation, I would want to start with a CT and a CTA.
Okay.
We can follow up with more MRIs after that.
Okay, sounds good. So we can definitely start with the CT. I think that's in terms of accessibility, that's the easiest step. And we see this, which we have previously seen. So how do you describe this lesion, Will?
I would say that it is a hyper dense lesion in the center of the brain, in the third ventricle. I would say there's not much mass effect around it or herniation.
Okay, great. So I think you described it very well. So that I would consider this a homogeneous hyperdense lesion in the anterior third ventricle. You can't tell from here, I haven't given you enough cuts, but there's not significant hydrocephalus. I can tell you that there aren't enlarged temporal horns or anything like that. Again, there's not significant mass effect. The third ventricle might be slightly enlarged. And we can see the corresponding MRI here. So there's a very broad differential for third ventricular lesions. Obviously, this is a lecture on colloid cysts, but it's very important to keep in mind in that not all lesions in the third ventricle are colloid cysts. So just to very briefly discuss things that you should keep in mind when you see a scan of a patient with a lesion in the third ventricle is that it can be a meningioma, it can be a giant cell astrocytoma or pilocytic astrocytoma. Hypothalamic hamartomas, while they may not be directly in the third ventricle, are obviously in this vicinity and should be on your initial differential. Xanthogranulomas can present here as well. And then also blood products. We see patients who have interventricular hemorrhage who, if you have IVH in the third ventricle or near the foramen Monro, so you see a good acute blood can also present hyperdense and can look similar. So as far as what we did with this patient, we admitted her to the SICU for close neuromonitoring and for watching developing hydrocephalus, given that she's had progressively worsening symptoms. And interestingly, on the first day, she became increasingly somnolent with worsening headaches. And so we actually took her directly to the operating room for endoscopic resection of the ventricular mass and placement of an external ventricular drain. The patient did very well on post-op day 1. We clamped her drain after draining her for a little less than 24 hours. There were no ICP issues. We had a post-op CTI, which you can see here, showing stable ventricles, and subsequently the EVD was removed and she was discharged home neurologically intact on post-op day 3. So I'm very briefly going to just go through some intraoperative pictures here. And at the end too, we'll share some more pictures, but here we can see the cyst. So this is the foramen Monroe, which is clearly expanded with choroid plexus on top here. Okay, and you can see this cystic mass really expanding the foramen Monroe here. And I won't go through this whole video, but then, so we ended up, sorry, I'll go back for a sec. So I'll talk about the steps a little later in the presentation, but a difficult technical point to this case was that she was on aspirin 81 and we weren't able to wait as long as we wanted to, as she was becoming progressively worsening and her mental status was deteriorating. So there was a little bit of oozing, which was great for me to see in terms of how to manage this with copious irrigation and bipolar cautery. There tends to be a lot of bleeding from the choroid plexus, which we see here, which we were able to control. And we ended up cauterizing all around the cyst wall here before being able to safely resect it. And then here, you can see that in addition to, right before resecting the cyst, we ended up making a septostomy in there. You can see the view of the contralateral, the left lateral ventricle wall there, showing that we are able to get patent flow through the septum pellucidum. So to take a step back and to talk a little bit more about this disease. So colloid cysts were actually first described by Wallman in cadavers in the 1850s. And then Dandy was actually the first one to treat colloid cyst in 1922. They were actually visualized with this picture. I'm not sure if anyone knows what this is. This might be a tough one. Actually, I'm not so familiar with this imaging.
The Newman cephalogram?
Nice, awesome. So this is a Newman cephalogram. Essentially, they inject air through and take an X-ray to better visualize the intracerebral or intracranial contents. So this is how they used to diagnose these lesions. It's pretty cool. Obviously, we don't use these anymore since CAT scans became popular in the 1970s. In terms of standard of care, we don't use these anymore. But I thought it was pretty cool. This is how they used to diagnose colloid cysts. They're not very common. They're only around 1% intracranial tumors, but a significant portion of intraventricular tumors, some reports have up to 20%. Most common type is neuroepithelial cysts, and a little over 3 of them are diagnosed annually. There are benign lesions. We'll talk about the pathology in a minute. And they're found in the third ventricle near the foramen Monroe. Interestingly, there's some variation with this, but some reports in case series show that over 50% can actually be symptomatic presentation, and we'll talk about why that's important later. And then these are some of the most common presenting symptoms: headache, nausea, vomiting, visual changes. And then there are actually a very significant portion of these are found incidentally. And the most common causes, or the most common ways they're found incidentally, include trauma, general medical workups, for example, a patient getting head CT for other non-neurological reasons or non-neurosurgical reasons. And then one question I had, Mike, since you're on a roll, is what do you think the mechanism of the headache is that this cyst is causing?
The mechanism of the headache?
Right.
For the hydrocephalus, not 100% sure on that. Maybe some stretching of some of the neural tracts kind of lining the ventricles.
That's a good guess. So it's a tough question. So it actually creates this transient ball valve effect. So think about the cyst as being at the foramen, and it creates, as CSF flows, it can create this transient ball valve effect that causes this transient obstruction, which becomes symptomatic and causes headaches. And then Pollock, a study out of Mayo, showed that the Tinger incidence of symptoms in patients under surveillance is actually only 8%, so it's not very high. So now, time to play the Chris Kellner family feud. Mike, what do you think is the most prevalent symptom? We just talked about it, but what do you think is the #1 symptom of both stable patients, asymptomatic patients, and patients who are having acute deterioration? #1 reason or #1 complaint?
Headache.
Yeah, exactly. Headaches. Great guess. So some other very common symptoms. So in the acute deteriorating patient, obviously altered mental status, compromised consciousness is very prevalent. Nausea, vomiting is also up there. Visual disturbances can definitely be seen. Gait disturbance, as we saw in our patient who came in, that was really her, in addition to the headaches, was her only objective finding on exam is that she has some gait difficulty. Cognitive impairment can be found, amnesia, and then something we often talk about is drop attacks. So sudden death, right? Sudden death is the anecdotal fear that we have with colloid cysts, and why that even though these are benign cysts, we take them very seriously, because we've seen that in not just the neurosurgery literature, but throughout the emergency medicine and pediatrics literature, that drop attacks can happen, and they're often associated with colloid cysts. So what's interesting is that the symptomatic rate of deterioration is very high, with a mortality rate of up to 12% in these patients who are acutely deteriorating. So you have to take these patients very seriously. This is not someone that you can say, oh, you can come back to my clinic next week and we'll go over this. If a patient is acutely deteriorating with a known history of a colloid cyst, you have to treat this as an emergency, and this is why. So what's kind of interesting is that we don't actually understand the true mechanism of the sudden death drop attack from colloid cysts. So there are two competing hypotheses that actually, there have been many studies to at least suggest both of these hypotheses, so we're still not 100% sure. So just to briefly describe these. So the one is the more common pathway that we associate with colloid cysts, and that it's an obstructive process, that by obstructing the flow of CSF, by blocking the framer in the third ventricle, the ventricles become dilated. We have increased ICP, causing herniation, compression, brainstem, further compromise, and death. However, there's this other arm, which is related to contraction band necrosis, that we think is kind of the other mechanism for the sudden drop attack. And this is all regulated by the hypothalamus. So the hypothalamus causes kind of transient changes in the autonomic function of the heart, which causes a catecholamine surge, which then leads to calcium channel activation and this CBN, contraction band necrosis. Again, these haven't been proven, but these are kind of the two working theories of why patients have this sudden attack from being normal, stable, to being dead very quickly. So in terms of imaging, Will did a great job earlier describing it. So the reason that we see this hyperdensity on CT is because this is a cyst very rich in protein cholesterol. On MRI, it's often hypointense, it's pretty much always hypointense on T2. This is due to the high viscosity of the cyst material. And it can actually be variable on T1. Some radiology studies show that about half the time it'll actually be hyperintense on T1. And then looking at what's actually inside these cysts. So the cyst wall is pretty much like any other cyst wall. It's simple columnar epithelium that may or may not be ciliated. It does stain for keratin and EMA. And then in terms of the cyst contents, it's composed of desquamated ghost cells. So essentially epithelial cells that have lost their nuclei and filamentous material. So there are no actually living cells within the cyst. And it does stain for PAS. And then in terms of the management, so there are several risk factors that are really important in assessing for colloid risk. And so Beaumont in 2016 did this study where they actually calculated a colloid cyst risk score, CCRS, where they're able to stratify patients based on high risk or low risk for deterioration. And they found that there are these 5 factors that are very important for assessing risk. So the first is age, whether the patient is over under 65 years old, whether a headache is prevalent, whether a headache is present upon admission, which, as Michael described, is very, very common. The axial diameter of the cyst with a cutoff of 7 millimeters was found to be important in terms of developing symptoms. Flare hyperintensity, was also present. And then the last is this idea of risk zones. So right here, we can see that, I don't know if you can see my mouse, but there's zones 1, 2, and 3, which correspond actually to these 3 pictures below. And so zone 1 here is coming from the lamina terminalis to the massa intermedia, and coming up to the most anterior tectum here. And then the third portion comes back to the posterior third ventricle. And so the reason why they separate these 3 zones is because these are the 3 zones that are at risk for developing obstructive hydrocephalus. Now, Will, going back to you, where do you think colloid cysts are most common between zones 1, 2, and 3?
I believe they're anterior, so zone 1.
Perfect, exactly. Yeah, so zone 1 is where we find the majority of our colloid cysts. So as you can see here, they can present in zones 2 and 3. But these are all 3 zones are considered risk zones. All right, so now going for a little anatomy. So before we talk about the surgical approaches. So there are 2 main arms of surgical approaches for treating colloid cysts. So the first is through an open craniotomy. And this includes either transcallosal or transcoracal approaches, which we'll briefly discuss. And then the second arm of resective treatment includes endoscopic or ventriculoscopic approach, which we'll spend a little bit more time talking on. Additionally, it's important to know that the treatment paradigm hasn't always been just resection. So for a while, these patients were treated with just VP shunts or ventricular peritoneal shunts. And then previously, there were also many reports on just doing stereotactic aspiration, that if this is a compressive problem, then just draining the cysts should improve the compression or the obstruction. However, what we saw, not surprisingly, is that by not taking out the cyst wall and just by draining the cyst contents, there's a high rate of recurrence or re-expansion of the cyst contents. So this no longer tends to be in favor in terms of standard of care. So, all right, we're going to start with the picture here on the left. So Halima, can you tell me what this is here? This band anteriorly?
Fornix?
Yep, exactly. And keep going because you're on a roll. What do you think this is here? It's the white matter tract anteriorly. All right, so it's the anterior commissure. And then how about here?
Lamina terminalis.
Perfect. Okay. And then going back to, or even lamina terminalis, but more of our ETV anatomy. This is our suprachiasmatic recess. And then how about just posterior to that? So here's our chiasm, and then I'll just finish it off here. So this is tuberostinarium, and then finally our mammillary bodies that we see posteriorly, which are obviously coming back from the fornix fibers. And then just to go over some of the permanent vasculature in this region. So Will, what do you think this is here? These paired structures. This is obviously a look from above, right? We're seeing both sides here. Okay, this is a picture from Rodin. So what do you think these vessels are?
Those the septal veins?
Perfect. Yeah, so these are anterior septal veins. Shoot, sorry. And these are the thalamic striate veins here. Okay. And then pretty sure this is next, but I don't want to ask you the wrong one. So yep, these are the mammillary bodies, the paired mammillary bodies that we see here. Okay. And how about these bigger veins back here?
Those would be the internal cerebral veins.
Awesome. Yep. So these are paired intercerebral veins. Right here, we have the posterior commissure. It's kind of hard to see. You can't see over here. And then the massa intermedia, which is just the connective tissue connecting both thalami, which don't have a significant functional structure. And then cerebral aqueduct is here posteriorly, right draining into the fourth ventricle, the body of the pharynx. It's here, pineal recess, and then lastly is our foramen and Monroe. Okay. So we're going to spend most of the time talking about the endoscopic approach, but just to be aware that there is a transcallosal and transcortical approach, which especially depending on the actual lesion can be more beneficial in terms of accessing the whole cyst. So in the transcallosal approach, we're coming from above, doing a interhemispheric approach. Okay, coming down, and again, this is kind of like Will described. This is the anatomy that we're going to see with the paired ICVs here with the foramen anteriorly. And Aaron Cohen-Goodall has a very nice video also going through the steps of how it performs procedure and the views and the corresponding rote anatomy as well. And then there is a transcortical approach as well, where you take an approach kind of similar to Coger's point, where you go from the frontal lobe, often from the right side, to access the lateral ventricle and to get down into the foramen and access into the foramen and Monroe. This approach is often used with a deep tubular retractor and can be very effective for larger tumors. And then finally, the approach that we're going to spend the most time talking about is the ventriculoscopic or endoscopic approach. So there's some advantages to the endoscopic approach that I feel like it really popularized it over the last couple of years. So the first is that it is a minimally invasive approach, right? Compared to the prior two approaches that I mentioned, you're making a small burr hole versus a larger craniotomy. The incision's about 2 centimeters. That's very small, minimally invasive. You're able to get excellent visualization, which we'll see pictures in a second, that you're truly able to access the anatomy from the right trajectory. It's a safe procedure. It's very efficacious. We'll go over some of the outcomes in a couple of slides. It's a short procedure. In some studies, the average length of OR time is under 90 minutes. And the hospital stay is often very short. Patients often only stay for a couple of days. Now, I'd be remiss if I said that the endoscopic approach should always be used and there are no disadvantages, right? Because there are obviously certain cases where an open craniotomy is better to be employed. So initially, there was reported that there's a much higher rate of residual cysts due to incomplete resection, with some reports showing upwards of 50, even close to 60% of residual cysts. And as we talked about before with the stereotactic aspiration, that when we just take out the cyst contents and don't take out the whole wall, that there is a big risk of recurrence. With larger lesions, especially lesions over 3 centimeters, it can be often difficult to resect through endoscopic means, and can be much easier to visualize larger lesions through an open craniotomy, where you're able to see more of the anatomy, regardless of if you're going transcortical or through the corpus callosum. And there is a learning curve with a working channel endoscopy, as we've seen with different technologies like MIS, TLIF, that there is a learning curve for surgeons. And I attribute some of the earlier results of having a higher residual cysts just to this learning curve, that even surgeons comfortable with endoscopy may not be as comfortable with using a working channel endoscopy in this manner. This could be a rationale for why the earlier results weren't as good. And you do need an assist. This really is a two-person job. It can be very challenging to both hold the endoscope and to be operating at the same time, kind of similar to anterior skull-based surgery, where it's much more helpful if you have someone who can hold the scope for you while you're using two hands to perform the surgery. And in a similar fashion of the open approaches, where they have their own complications, they're similar complications to the endoscopic approach. It's, as you can imagine, with all the venous structures we named nearby, it's easy to cause venous injury. Memory deficits, as we saw there's very close association to the pharynx fibers, to where the scope is. And however, it's important to keep in mind that many of the complications that are seen in endoscopy are also the same complications seen in open craniotomy. So as far as the technique, what's been commonly reported is the use of a 30-degree working channel endoscope, which based on the trajectory that I'll mention in a sec is really the easiest way to visualize the foramen and gain to the anterior third ventricle. So it's very, the reason also why it's important to use a 30-degree working channel endoscope and not just the straight endoscope is that it's important to visualize the roof of the third ventricle. So Mike, why do you think it's important specifically to look at the roof of the third ventricle here?
I'm not too sure.
Lima?
So one, that mostly they're located anterior superiorly, so you want to make sure that you have visualization of the actual cyst. And secondly, to prevent any damage to surrounding structures such as fornix.
Right, so that's important. What I was getting at a little bit more is that the roof of the third ventricle is actually where these lesions originate from. So the thoughts come from the roof here. And so you want to make sure you have a really nice plane and helping to dissect off the cyst. Let's see. And as I mentioned before, and I showed in the video, using a working channel endoscope can be really nice to help visualize and dissect the cyst, to remove it, as well as to access the choroid plexus, which can be really important in terms of controlling hemostasis. So the one thing I really didn't appreciate before I was able to see a couple of these cases with Dr. Hadjipannyis is the approach. And Dr. Hadjipannyis really made me appreciate how your entry point and your trajectory are really the whole surgery, that you really disadvantage yourself by not creating the right angle and trajectory into the foramen. Another reason why I think some of the earlier reports had such high residual rates is because people weren't using kind of a really standard trajectory and standard entry to resect these lesions. So at first, a lot of people were using points near Coker's point. And what I appreciate you kind of playing with the navigation a little bit is by using Coker's point, it really doesn't open the foramen up enough. I think that we think that using the same trajectory as an EVD, oh, we're shooting for the foramen, this should be a nice approach. But really, when you get more lateral, you get really anterior and lateral, it really opens up the foramen for you, and it gives you a really nice corridor to work in to get to the cyst and to be able to dissect around it and create a nice plane for yourself. So the anterolateral approach, which has been described in the literature, especially by Dr. Hadjipannyis, is that you go 8 centimeters up from the glabella, 5 centimeters lateral. So you're going a lot more lateral than you would for like a standard EVD. And you make a 2 centimeter incision, and by being perpendicular at this point, this will really open up the foramen for you and give you a nice corridor to accessing the cyst. So this is what this looks like in the operating room. So obviously the potentially problematic thing here is the cosmesis, that someone, say with a higher hairline, this is going to be really high in the forehead. But again, this does really give you the best view accessing these lesions. So I just mentioned these landmarks. You don't have to use a huge burr hole. 7 millimeters is fine for most working channel endoscopes that we use. And then this corresponds with a 19.5 French or 6 millimeter peel away sheath trocar that we use to access the ventricle. So in terms of operating room setup, tends to be pretty standard supine with a little bit of a head turn. Depending on the patient's neck, can give a little bit of a bump under it. Obviously, this is all used under navigation here. So I thought this was really cool. They had a navigated trocar, which we don't have here, but we use essentially an EM stylet, which does the same thing. So we navigate down to the foramen. And after we place the trocar in, similar to an ETV, we peel it away and staple it back with our retractor. Okay, and then just to beat the anatomy down, so Will, can you start by telling me what this is here?
Is that the foramen of, no, the foramen of Monroe?
Right, exactly. It's actually the cyst, but this is where the foramen would be. Oh, I'm going over. I apologize. So this is septal vein. Choroid plexus is here. Thalamic vein is kind of hard to see, but you can see it kind of coursing down in here. And then this is the cyst, which is what I was trying to get at. And then we can see how close the fornix fibers are, right? So the fornix fibers run here, right in front. So, you know, when we talk about memory problems and why we have to be very careful to not cause excessive damage to the fornix fibers, we can really appreciate the relationship here that especially larger cysts that may be pushing up on the fornix, that we have to be very careful when we're using our bipolar cautery to make sure we're not excessively damaging the fornix fibers. And then here, so after we start bipolaring the cyst, the wall really shrinks down and creates a much easier plane for us to work in. And then we can see here that after resection, we can really appreciate how much the foramen of Monroe shrinks down, right? And then one thing that we look for, so this is for our septostomy. What do you think this is, Will? This is kind of what we look for on the other side. It's a little hole here.
That is the septostomy?
Right, so we're creating a septostomy and we're looking contralaterally now. So what do you think this hole would be?
The lateral ventricle?
So correct. So this is the lateral ventricle. So we're approaching from the right side. So we're looking here through the septum at the left lateral ventricle, and right. we see a hole here. So what would this hole be?
I think it would be the other lateral ventricle.
So close, right? So it'd be the contralateral foramen of Monroe, right? Okay. So that's what we look for. That we want to make sure that we can visualize the opposite lateral ventricle, and we can see the foramen as well. The foramen are actually not that far from each other. So we often place an external ventricular drain, and we may drain the patient for 1 to 2 days after. And now to talk about some endoscopic outcomes, and Dr. Hadjipannyis' group, when he was back at Emory, did a nice job describing this, is that they outlined over 50 patients who underwent this resection using the same approach I just described with the anterior lateral approach. And interestingly, 60% of their patients presented with obstructive hydrocephalus, but 41% without ventriculomegaly. All the patients had an EVD placed in the operating room. Okay. And the majority of them had a fenestration of the septum pellucidum or septostomy. So one great thing about this series is they actually had really nice follow-up with almost all of their patients. And what they found is that 100% had complete resection and follow-up imaging. There was only one recurrence of their experience with a mean OR time of 82 minutes. So much faster than we would get from an open craniotomy, with a median length of stay of 5 days. And then we can see here, we talked about the fornix fibers, and memory loss is always something we worry about in the post-op phase. We're always asking our patients questions to try to elicit their memory in the post-op period. And what they found is that 6 patients did have transient memory loss. However, they did improve. And then over 92% of these patients were discharged home. Then another part of the study, which I thought was really interesting, was they looked at patient satisfaction and quality of life, which I feel like is something that in cranial surgery, we don't always really emphasize, of how these patients do, not just in terms of disposition to going home versus to a rehab center, but are these patients able to actually return to their previous quality of life? And so what I thought was great was that 85% of these patients were working prior to surgery, and 37 of these 40 patients were able to return to their full-time job after surgery with a 100% satisfaction rate. So it shows that this procedure is not only safe, but it's efficacious too, and these patients are actually coming back relatively quickly after 5 weeks to their initial quality of life. So interesting part of this study that I was interested in, because I wasn't so sure before preparing this talk of the need for shunt dependence, and how often these patients who have at times this chronic obstructive process, how often do they need shunt dependence, because it's thrown off their CSF compliance. And so what's interesting is that 2 of the 3 patients who had a prior VP shunt had their shunt removed and were able to achieve shunt freedom after this procedure. 3 of the patients did require shunt placement after cyst removal. This included 1 patient who had a shunt that was removed during surgery and then needed to be shunted later on. One patient did develop post-op communicating hydrocephalus, and another patient had post-op intraventricular hemorrhage that required an EVD, and after needing to be drained for a certain number of days, needed to go on and again ETV and receive a shunt. So just to summarize some of the things we talked about and some of our findings. So there are certain really important clinical factors that when you're assessing a patient and you're consulted on a patient with a colloid cyst, these are important things to keep in mind because they can be predictive of acute deterioration. So these 5 things are age, presence of headache upon admission, axial diameter on imaging of 7 millimeters or more, flare intensity on MRI, and wrist zone, those 3 wrist zones that we described earlier. And this is really important to determine because in patients who do have some of these risk factors, there is a significant risk of acute deterioration, especially if they're symptomatic. And keep in mind that these patients can present with symptoms in many different ways. They don't always have to have headaches. They could have some weird memory problems, some gait instability, nausea, vomiting, different cognitive presentations. So you have to keep an open mind when talking to the patient who has a known history of a colloid cyst to really understand their symptoms. And then there are many surgical treatment options. Here we're obviously a little biased with the endoscopic approach, but it's important to keep in mind that for larger lesions or based on the patient's anatomy, it may lend more favorable to a transcallosal or transcortical approach. However, it's important to keep in mind that all of these procedures have their potential shortcomings, that at least initially it was reported that endoscopy had higher rates of residual cysts, and transcallosal approaches have been reported having higher rates of shunt dependence post-op, high rates of infection, longer length of stays, et cetera. However, what's important is that despite these potential complications, there were similar outcomes between open versus endoscopic approaches. So I just want to finish with 2 brief questions, and we have 2 awesome sub-Is this month, so I'll split them between you guys. So Mike, if you want to take the first one. So these are all things we talked about during the lecture today. So which of the following was not a risk factor in the CCRS?
Hydrocephalus.
Perfect. So it's headache, not hydrocephalus. That was one of the known risk factors. And then Will, where do colloid cysts most commonly originate?
We said the roof of the 3rd ventricle.
Exactly. Perfect. Nice job, guys. All right. And I just wanted to thank Dr. Hadjipannyis for helping me prepare this talk, obviously for his effort and for helping show us his technique. Thank you guys so much for your time.